We're talking about the respiratory system and stopped here in last class. Uh, so, the lung, you have two lungs, right and left, and interestingly, lung receives two types of blood flow, systemic as well as pulmonary. You know there are two types of circulation, right? Systemic circulation and pulmonary circulation. Both types of circulation are present in the lungs. Okay. Pulmonary circulation, you know, it is the circulation between the heart and the lungs, right? And heart sends blood to the lungs to get oxygen. Blood goes to the lungs to get the oxygen, right? And brings the oxygenated blood back into the heart. That is the pulmonary circulation. Make sense? So blood goes to get oxygen and comes back with oxygen. Now, systemic circulation also gives blood to the lung, because systemic circulation is the circulation between the heart and the whole body, right? And lungs are the part of your whole body, and lungs also needs oxygen and nutrition, because lung tissue needs metabolism, right? So needs oxygen and nutrition. So systemic circulation goes to the lung tissue to provide oxygen and nutrition for the survival of lung tissue. So both pulmonary and systemic circulation are present in the lungs. Now, pulmonary circulation includes pulmonary arteries that get deoxygenated blood to the lungs, and pulmonary veins, you already know that, bring oxygenated blood back into the heart. So these are the blood vessels of pulmonary circulation. Now, systemic. Systemic blood vessels are called bronchial vessels. That means bronchial arteries and bronchial veins. Bronchial arteries take oxygen and nutrition to the lung tissue and bring deoxygenated blood, carbon dioxide, back. So both are present in the lungs. Just write it down. Pleura, coverings of the lungs. Like your heart, your lungs are also covered by a double layered membranous structure that is called the pleura. Double layered membranous structure, also called serous membrane. Double layered serous, S-E-R-O-U-S membrane. Outer layer is the parietal, inner layer is the visceral, like pericardium. And in between these two layers, you have a space that is called the pleural cavity, and it contains small amount of fluid. That fluid is the pleural fluid, and that reduces the friction when lung expands and contracts, right? These two layers move like this, and because of that fluid, they won't rub each other, friction won't occur. because that fluid is lubricating type fluid, and that prevents the friction between those two layers, like pericardium. So sometimes infection can cause inflammation of the pleura, and that inflammation of the pleura is termed as pleurisy or pleuritis. We use both. Itis, itis indicates inflammation, right? So pleuritis is the inflammation of pleura. Also called pleuris. So same thing, inflammation of the pleura. That can cause pain, sometimes can cause fever. So that's the pleura and its layers and the function. Mechanism of breathing. How inspiration and expiration take place. You know that respiration or breathing has two phases. Inspiration is an active process because inspiration needs muscle contraction, active muscle contraction. Expiration or exhalation is a passive process because you don't need muscle contraction to exhale the air. So inspiration is active, expiration is passive. And why? Because inspiration needs the contraction of the respiratory muscles. So what are the respiratory muscles? First you need to know intercostals. There are two intercostals, external and internal. Okay, intercostals. In between the ribs, you know, inter means in between, costal indicates ribs. So in between the ribs, you have external intercostals like this, and internal intercostal is like this. Make sense? So external, internal. So two intercostals. And also another very important muscle is located here, that is also respiratory muscle, that is called what? Diaphragm. Okay. Now when intercostal muscles contract, they move the ribs forward and upward like this. You see, forward, not only forward like this, forward and upward. So the ribs move forward and upward when intercostal muscle contracts, and that expands the lung. You see, when the ribs move this way, the thoracic cavity gets bigger this way, and that expands the lung, pulls the lung this way. So lung gets expanded anterior posteriorly this way. Anterior posteriorly lung expands. When diaphragm contracts, you see, this is also important, diaphragm moves downwards. So diaphragm moves downwards when it contracts, and that pulls the bottom of the lung, base of the lung downwards, because diaphragm is attached to the bottom of the lung. So when diaphragm moves, it pulls the bottom of the lung downwards. So the lung expands vertically this way. So intercostal muscles expand this way, anterior posteriorly, and diaphragm expands vertically, superior inferiorly. So what happens? The diaphragm and intercostal, they together expand the lung, right? So inside the lung the space gets bigger. Make sense? And a negative pressure is created there. So from outside air gets in. That is inspiration. Air always moves from high pressure to low pressure. Remember, this is the rule, right? Air moves from high pressure to low pressure. When lung expands, pressure decreases inside it. So the air gets in. That is inspiration. And after that, when these muscles relax, what happens? Lung is highly elastic, right? That's why it can expand. Lung is highly what? Elastic. So if you expand it by pressure, when the pressure is gone, what will happen? It will get smaller, right? So when the lung is getting smaller, that is called recoiling, right? Pressure will start to increase inside, right? Because it's getting smaller. So pressure inside the lung will move up, and at one point then pressure is high enough to push the air to the outside. So that is the expiration. So which one is active? Inspiration, because muscle contraction is needed, right? But recoiling doesn't need pressure. Like just think that something elastic, when you pull you need pressure, right, to expand it. But if you leave that, it will recoil. Doesn't need to use pressure. So exactly same way, expiration occurs due to recoiling of the lung tissue. That is normal breathing, normal inspiration and expiration. Now you see, if I ask you to forcefully expire more air outside, you need pressure, right? Normal expiration you don't need. But if I ask you to push more air out, then you have to use pressure, right? So forceful expiration is active, not normal expiration. Okay? Forceful expiration is an active process. How the gases, oxygen and carbon dioxide, move from one place to another. Oxygen and carbon dioxide move by pressure difference, because I told you gas always moves from high pressure to low pressure. So that pressure difference moves the gas, oxygen and carbon dioxide, from one place to another. So to understand how the gas moves, you need to know the amount of pressure in different areas. First, let's talk about the lung. Okay. Inside the alveolus, the pressure of oxygen and carbon dioxide. And you know that on the surface of the alveolus we have the capillary. We had talked about that in last class, and blood is here. So this is blood. Okay, and now you tell me why blood goes to the lung to get the, everybody, oxygen, right? So you already know that oxygen should enter into the blood. Is it clear? Oxygen should go to the blood. So now you tell me, to move the oxygen from here to here, where the pressure should be higher? Here, right? Because gas moves from high pressure to low pressure. Very simple, right? So pressure of oxygen should be higher here. Is it clear? So inside the alveolus, the pressure of oxygen is 104 millimeter of mercury. oxygen pressure is 104 millimeter of mercury. Okay. And in the blood, the pressure of oxygen when the blood enters into the lung is only 40 millimeter of mercury. Oxygen. We are talking about oxygen. Okay. So what is the difference here? Big difference, right? 64 millimeter of mercury. Is it clear? The difference is how much? 64 millimeter of mercury. It's a big difference, right? So oxygen will move from the high pressure to low pressure. That's how the blood gets oxygen from the lung. Is it clear? From the alveoli. Okay. Now carbon dioxide moves always in opposite direction. You remember in last class I mentioned that you remember carbon dioxide always moves in opposite direction. So which way carbon dioxide will move? From the blood to the alveolus. Is it clear? And carbon dioxide pressure then must be higher here and lower here, right? That will move carbon dioxide from here to here. So what is the pressure of carbon dioxide in the blood? Carbon dioxide pressure is 45 millimeter of mercury in the blood, and carbon dioxide pressure is 40 millimeter of mercury inside. So what is the difference? How much? 5 millimeter of mercury, right? So because of that difference, 5 millimeter of mercury, carbon dioxide will move from the blood to the alveolus. So you see how the gas exchange occurs inside where? The lung. Blood gets oxygen and lung gets carbon dioxide from the blood. Now let's go to the tissue. After blood gets the oxygen, blood takes the oxygen to the tissue, right? Deliver the oxygen to the tissue because tissue needs oxygen. So let's see what happens in the tissue. In the tissue, these are the cells. You know, tissue consists of cells and the capillary. So this capillary brought the blood into the tissue. And in the tissue, the pressure of oxygen must be higher in the blood and lower in the tissue, because oxygen should go this way from the blood to the tissue, right? Blood goes to the tissue to give oxygen. So oxygen must be higher, pressure should be higher in the blood and lower in the tissue. And carbon dioxide pressure is higher in the tissue and lower in the blood. So carbon dioxide will move from the tissue to the blood, always in opposite direction. If you know one, you know the other, right? So blood goes why to the tissue to give oxygen. So the pressure is low in the tissue. And if you see here, the pressure of oxygen here is 100 millimeter of mercury. Oxygen pressure in the capillary blood is 100 millimeter of mercury, and here in the tissue is only 40 millimeter of mercury. So the difference is 60 here, and because of that difference, 60 millimeter of mercury difference, oxygen will move from high to low. So tissue will get the oxygen. That's how tissue is always getting the oxygen. Okay, and carbon dioxide pressure is higher in the tissue. It is 45 millimeter of mercury, and in the blood is 40. So 5 millimeter of mercury pressure difference of carbon dioxide will move the carbon dioxide from the tissue to the blood. So blood will get the carbon dioxide and give the oxygen to the tissue. So after giving the oxygen to the tissue and getting the carbon dioxide from the tissue, the blood gradually becomes deoxygenated, right? So oxygenated blood becomes deoxygenated and goes to the heart, right atrium of the heart, right? And then we'll go to the lung to get the oxygen again. So you see here that pressure is important, pressure of oxygen and carbon dioxide, because pressure difference moves the gas from one compartment to another. Okay, so now you know what happens in the lung, what happens in the tissue. Now interesting question, just for your information, you see here, when the blood leaves the lung, the pressure of oxygen eventually finally becomes 104. Same, because until then the oxygen will keep going to the blood. So when blood leaves the lung, the pressure of oxygen increases up to 104, equal to inside. Now when the blood arrives in the tissue, the pressure drops a little bit from 104 to 100. Slightly, the pressure of oxygen drops. Why that happens? In some places in your body, arteries and veins are connected only in few areas. Arteriovenous anastomosis we have somewhere, okay, in few places. So some deoxygenated blood goes to oxygenated, they get mixed a little bit, okay. So that's why the pressure of oxygen goes down a little bit, and but very little. Anyway, so that is one thing. No. Okay. Now another pressure which is also important to move the air from the atmosphere to the lung and expel the air from the lung to outside. You already know that when lung expands, right, pressure inside the lung decreases, goes down, right? So that takes the air from outside to inside. You need to know how much difference of pressure moves that gas. What's the pressure inside the lung and outside of the body? So three pressures you need to know. One is called the atmospheric pressure. At the sea level where we live outside of the body, the pressure of gas is 760 millimeter of mercury at the sea level where we are living. That's outside of the body, the pressure of gas. Inside the lung, that is called intrapulmonary. Intra means inside, pulmonary means lung. So inside the lung, the pressure of gas changes. Why? You know that already, right? When lung expands, pressure goes down, right? When lung contracts, pressure goes up. So that's why it is not fixed. It is changing, right? So intrapulmonary pressure is not fixed, but changes between what? In narrow range, 759 to 761 millimeter of mercury. Is it clear? Now you tell me, when your lung has expanded, okay, the pressure is low, right, inside. So that pressure is this, right? Is it clear? When lung has required, the pressure is high, right? That means 761 inside the lung, okay. Now see this one. When lung expands, the pressure goes down to what? 759, right? And outside of the body, here the pressure is always fixed. What is that? 760, right? So now you tell me which way the gas will move, from high to low. That means from outside to inside the lung. Is it clear? What's the difference? Only 1 millimeter of mercury, right? But that 1 millimeter of mercury pressure difference is strong enough to move the gas, move the air. Okay? Yes.
So in asthma, when you have ventilation, you don't
Shortness of breathing, yeah, shortness of breathing can take a lot of air inside, right? Now, when the lung starts to recoil, the pressure inside starts to increase, right? And at one point it goes up to 761, and when it becomes 761, higher is here, lower is outside of the body, right? So the gas will get out. That 1 millimeter of mercury pressure difference is enough to move the gas in and out. Okay, and that's how inspiration and expiration occurs. Now there is another pressure which is also very important, that is called intrapleural pressure. That means inside the pleural cavity between parietal and visceral layers. That pressure is 756 millimeter of mercury. What is that pressure? You see, this is the lung and this is the visceral layer, then this is the parietal layer. Here, this is the pleural cavity where you have that fluid, lubricant fluid, and there's some space, there is some space here, and the pressure there is 756. Now inside the lung, interpulmonary is 759 to 761, changing. But see here, one thing which is important to note, that even when interpulmonary pressure is low, that means 759, right? It is still higher than 756. That means what? That means around the lung, outside of the lung, in the pleural cavity, the pressure is always what? Low. Makes sense? Because inside the lung is this, right? And outside is what? 756, always. So always around the lung the pressure is what? Lower. And that negative pressure must be there always, lower pressure, to keep the lung expanded in some extent. Otherwise lung will collapse. If just think, it is very simple. If around the lung the pressure is high, then what will happen? That will press the lung, right? Will not be able to, lung will not be able to expand. Clear? So always around the lung you must have negative pressure. Even when you are expiring the air, lung is getting smaller, but it will not collapse completely. Make sense? It will stay expanded in some extent, which is very important. Otherwise lung will completely collapse.
Does that have to be punctured to collapse?
Yes. Now, yeah, very good question. You say that if I stab, I don't want to. Okay. So if you get stabbed by a knife, right, goes like this. If you can make a hole here, then what will happen? Outside of the body, the pressure is what? 760, right? Atmospheric pressure outside. So here is always less. So what will happen? The air will get in, right? And the pressure will increase here. So lung will not be able to expand. Make sense? So because the air is getting in from high pressure to low pressure, that will cause the collapse of the lung. So you need to know these three pressures to understand how expiration, inspiration take place, and why interpleural pressure should be always minus or negative or less. How much negative? Like 3 to 5 millimeter of mercury. 3 to 5, minus 3 to minus 5. You see 1 millimeter of mercury causes the movement of the air. we talked about surfactant in last class. Surfactant is secreted from type 2 surfactant secreting cells in the alveolar wall, and that fluid keeps the alveoli open, reduces the surface tension in the alveolar wall, and keeps the alveoli open. Due to lack of surfactant, infants can suffer from respiratory distress, infant respiratory distress syndrome, I or DS, that I talked about last class. Okay. Okay. So about the respiratory volumes and capacities. Respiratory volumes and capacities are important. Why? We measure these volumes and capacities to test the lung function. Make sense? How your lungs are functioning. Lung function test. So we'll see the normal volumes and capacities. There are 4 volumes and 4 capacities. Partial pressure of gas and movement of gas, that I explained you in the lung, what are the pressures in the tissue, what are the pressures, that part we have already finished. Okay. Factors influences the oxygen saturation. Yes.
So like, since it's like on top of a mountain, like is the atmospheric pressure lower, so it's hard to breathe?
Yeah, it is hard to breathe. Yeah, hard to breathe, and that's why you need to carry the oxygen. If it's really high, yeah, high altitude, the pressure of oxygen is low. Yeah. Factors influence the oxygen saturation. What is that? You know that blood has hemoglobin, right? You already know. So hemoglobin binds with oxygen, right? So what are the factors that can change that binding, the amount of binding? Make sense? So we'll just talk about that. In some conditions the binding will be more, in some conditions the binding will be less. Okay. So that is the saturation, oxyhemoglobin saturation. Then we'll talk about the regulation of breathing or respiration. In your brain you have the respiratory centers. We'll see where they are located and how they regulate the breathing. Then we'll talk about a couple of clinical conditions. Okay, so there are 4 volumes and 4 capacities. Volumes are tidal volume or TD, inspiratory reserve volume or IRV, expiratory reserve volume ERV, and residual volume RV. So tidal volume is the amount of air or volume of air that we inspire and expire in normal quiet breathing. You are in resting condition, right? How much air you are taking in, same amount of air you are expelling, and that amount is 500 milliliter, half a liter. That is normal quiet breathing. Make sense? Inspiratory reserve volume. What is that? Now you see, look at me. After you take normal amount of air, 500 milliliter, right? If I ask you, stop there after you take that 500 and now try to take more. Can you do that? You have taken 500 normal inspiration, right? Now if I ask you, try to take more. You can do that, right? Like you see, normal. I can take a lot more, right? But we don't, normally we don't, right? But when you do exercise, right, you take more. So that's the inspiratory reserve volume. the volume of air or amount of air that you can forcefully inspire after you finish what? Normal inspiration. Is it clear? So after you finish your normal inspiration, the amount of air you can take forcefully. That is the inspiratory reserve volume. Give me an example when you do that. You take more air before go under the water, right? Like you will try to take a lot of air inside, right? And then dive. So that's the inspiratory reserve volume. Very simple, the word you see reserve. You can do that, but normally you don't do, right? That is the reserve amount. We don't use the reserve force always, right? When we need, we do that, right? So when you need, you use that amount. That's a lot. In adult male, it is 3.1 liter. That means 3100 milliliter. And in female, it's less, 1.9 liter, 1900 milliliter. Why it is smaller in female? Very simple. The surface area, right? The size, average size, and also the strength of the muscles, diaphragm and intercostal muscle. Two things are here. Why? The inspiratory reserve volume is more in male than female, because one is the size or surface area of the lung, and another is the muscle. The muscles are stronger, usually, not always, right? But sometimes the girls are very strong. So that's average. When we talk, we don't indicate individual person, average. Diaphragm can contract more forcefully. Intercostals can contract more forcefully in male. Expiratory reserve volume, just opposite. After you finish normal expiration, 500, like normal expiration. Now if I ask you forcefully try to expel more, I can do more, right? So the amount of air that you can forcefully expire after normal expiration. Very simple. The amount of air you can forcefully expire after normal expiration. When you do that, can you give me an example? Like when you do that, when you use that reserve, expiratory reserve volume. Better example. If I give you a balloon and tell you, your kids sometimes give you, right? Mom, can you blow it for me? You do that, right? It forcefully expire the air, right? So that's the expiratory reserve volume. Also, the volume is more in male than female because of the size and muscle strength. Residual volume. The volume of or amount of air remaining in the lung after forceful expiration. Now if I tell you, you'll look at me, if I tell you, try to expel all the air out from your lungs forcefully, right? After you do that, still some air remains in the lung that you will never be able to expel out, okay? You will not be able to expel out. That amount of air that remains in the lung after you forcefully expire all the air, right? Air out, that amount is called the residual volume. Now, why some air always must be inside the lung, inside the alveoli? It is very important because of two reasons. If all the air gets out, right? Just think that if all the air gets out, then what will happen? The lung will try to, the alveoli with no air inside the alveoli, so alveoli will squeeze, right? Will collapse, number one. So prevent the collapse. Residual volume prevents the collapse of the alveoli. Is it clear? So some air will remain. Number two, this is also important. If you expel all the air out from the lung, that you cannot do, then blood is always going to the lung, right, to get the oxygen. Blood is not stopping to go into the lung. Blood is always going, right? So blood will come back without any oxygen, right? So the carbon dioxide level will quickly go up, suddenly increase. Oxygen level will suddenly what? Drop. Make sense? Because blood is going but not getting anything. Residual volume ensures that some air is always inside the lung, even if you forcefully expire. Is it clear? So blood will go and at least get something, right? Some oxygen. So the change will not be sudden. Sudden change is not good. So residual volume keeps the alveoli open and ensures that blood does not return from the lung without getting any oxygen. Okay. Now capacities. We get the capacities by adding the volumes, 2 or more volumes. Very simple. We add 2 or more volumes to get the capacities. Inspiratory capacity, functional residual capacity, vital capacity, total lung capacity. So you see here, total lung capacity, this is very easy because total, if you add all 4 volumes that we have talked about together, that will give you a total lung capacity. That means what? Tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. Right? Those are 4 volumes. So if you add all of them together, that will give you a total lung capacity, which is higher in male, again lower in female. Vital capacity, if you add 3 volumes, tidal volume, inspiratory reserve volume and expiratory reserve volume, together that gives you the vital capacity. Inspiratory capacity, if you just add tidal volume and inspiratory reserve volume, that gives you inspiratory capacity. That means how much total amount of air you are taking forcefully altogether. How much air you are taking forcefully. And functional residual capacity is the volume of air remaining in the lung after normal tidal volume expiration. So 2 things here. You see, this is functional residual capacity, and before you got what? You see here, residual volume. Now let me just talk about these 2. Residual volume, you already know, if I try to forcefully expire all the air out, still some air remains in the lung, right? That is the residual volume. And functional residual capacity is the volume of air remains in the lung after normal expiration, not forceful. So always that is happening. You are doing normal expiration, and after that how much volume is remaining in the lung. So these are the capacities. Just you don't have to remember all these numbers. You mark the following ones are important more. Tidal volume, you need to know, both male and female, same amount, 500 milliliter. You need to know the residual volume. Okay, residual volume, that is important. Total lung capacity, male and female. Okay, those are important ones. Also vital capacity, mark the vital capacity. Okay, so this few, make sure you remember. Okay. This is a nice chart that is showing those volumes and capacities. Very simple. Normal breathing. You know that when we do normal breathing, this is showing the range of normal breathing, 500 milliliter, right? So just remember, when you look at this chart, it is showing the volume of air inside the lung, amount of air inside the lung. Okay. Now you tell me, when you expel the air out inside the lung, the volume gets what? You expel the air out inside the lung, volume goes up or down? That's a simple question. When you exhale the air inside the lung, the air goes down or up? Down, right? Because you are expelling the air. So when the curve moves this way, that means what? Expiration, right? Exhalation. The volume is going down. And when it is going up, that is inspiration. So you see here, normal expiration 500, normal inspiration, normal expiration, normal inspiration. Okay? So this is 500 milliliter. This amount, 500 milliliter, right? And that is normal breathing. Now, after you see normal inspiration here, you finished normal amount of, look at me, you finished normal inspiration, right? You have taken 500 milliliter inside, right? So that's why it is moving up. So now if I ask you stop there and forcefully take more air inside the lung, make sense? So this amount is what? Inspiratory reserve volume, because you are forcefully taking, right? After normal. Now you come back to normal again. This is again normal, normal inspiration, normal expiration. Now you look at me. This is normal expiration. You have expelled 500 milliliter out, that's why it went down. Now if I ask you, expel more forcefully, you can do that. So this amount is the expiratory reserve volume. Expiratory reserve volume. This amount is the inspiratory reserve volume. Now, after forceful expiration, you see here, I told you, after forceful expiration, still some amount of air remains inside the lung. That is the residual volume. So after forceful, you stop here, then still some air remains. So that's the residual volume you see here. So now you will understand the chart if you just see this chart, and after you go to your home, it will be easy for you to understand. Okay. And in the right side, you see the white boxes. Those are showing the capacities. You add 2 or more of those volumes to get the capacity. Dead space. Dead space is the area where no gas exchange occurs. I am repeating again, very simple way. I said dead space is the area where no gas exchange occurs. Make sense? Now you must remember, everybody, we divide the entire respiratory system into 2 parts. Anybody remember? In one part, what happens? One part is only for what? Passage of gas, right? Transport, you remember? And in last 3 structures, what happens? Gas exchange occurs. Is it clear? You remember from last lecture? Okay. So, from the nose to the terminal bronchiole, no gas exchange occurs. Remember that? So that part is called the conducting zone. You also remember that, right? Conducting zone. So is that a dead space or not? Just think and tell me. Yes, because no gas exchange occurs there, right? No gas exchange occurs. So that entire area from the nose to the terminal bronchiole is what? Dead space. Is it clear? That is called anatomical dead space, from nose to all the way to the terminal bronchiole. Very simple, because these are just for the passage of gas. not for gas exchange. Those are designed, right, to transport the gas. Your nasal cavity, your larynx, pharynx, trachea, bronchi, right? Those are just to take the air from outside to inside. Is it clear? So that's the anatomical dead space, because the structure was designed to do that, not for gas exchange. So that is one. There is another dead space that is called alveolar dead space. What is this? You know that gas exchange occurs in the alveoli, right? Gas exchange occurs in the alveoli. Then why we are talking about alveolar dead space? Just very simple. You see here, this is the alveolar duct, respiratory bronchial alveolar duct, alveolar. You must remember this. I showed you in last class. Gas exchange occurs in these three structures: respiratory bronchial, alveolar duct, and alveoli. Now you see, all these alveoli, if they function normally, gas exchange will occur through the wall. Now, if any blockage occurs here in the middle duct, alveolar duct here, then what will happen? These alveoli will not get any air. Is it clear? If any blockage occurs here, these alveoli are getting air, but these are not, because the duct is closed here. Is it clear? So now these alveoli are not taking part in gas exchange, because they are not getting gas. They are not getting air from outside. Is it clear? Blood is going there, but will not get gas. So now we can tell that these alveoli are dead space, because no exchange is occurring. So that's the alveolar dead space. In clinical conditions, like if someone has bronchitis, right? Very narrow bronchioles get obstructed, blocked, right? Or if someone smokes a lot, right? Chronic smoker, these tiny ducts can get closed, and alveoli, many alveoli may not get air from outside. Okay? So the alveolar dead space can be created, right, in clinical conditions. Yes, if you do exercise regular, the chance of getting blocked is less, because you are taking a lot of air, right, forcefully. So will clear up. So that is one thing. And medicine, of course, can dilate the bronchioles, and gas will be able to. So many ways you can treat. So which one is fixed? What do you think? Anatomical is fixed, right? The volume inside the nasal cavity, trachea, larynx, those are fixed. But alveolar dead space is not fixed. It can be changed. Total dead space, if you add those together, anatomical and alveolar, that will give you total dead space. Carbon dioxide moves. How they move, okay, we have talked about that. Ventilation, perfusion, coupling. What is this? You see here, ventilation, pulmonary ventilation. That means breathing. Ventilation means breathing, pulmonary ventilation. And perfusion is what? Perfusion is heart is sending blood to the lung, right? When heart contracts, blood goes to the lung. And the flow of blood in the lung, that is the perfusion. So I am repeating again. Ventilation is what? Breathing, right? And perfusion is what? Flow of blood in the lungs. Is it clear? Perfusion. Those two things should happen in timely manner at the same time. Both should happen what? At the same time. Why? Just think that when you have taken air inside your lung from outside, right? At the same time, blood should go there. if blood goes there after you expel the air out, then blood will get less oxygen. Is it clear? So heart should send the blood, or perfusion should occur when you inspire the air. Is it clear? If blood goes there after you expired the air out, less oxygen blood will get. So those two things should happen at the same time, and that is important to ensure that blood is getting enough oxygen, good amount of oxygen. Okay. Just one thing I will mention is, you must remember that oxygen moved from the alveolus to the blood. The pressure difference was 64 because 104 here, 40 here. 64 millimeter of mercury. And carbon dioxide moved from the blood to the alveoli, only the pressure difference was what? 5. So 45 here and 40 here. So 5 millimeter of mercury here difference moves carbon dioxide. 64 millimeter of mercury here difference moves the oxygen. But same amount of oxygen and carbon dioxide are moving. Why? Because the respiratory membrane through which the gas exchange occurs allows carbon dioxide to move faster than the oxygen. Carbon dioxide is, we say, more soluble through the respiratory membrane, so it can quickly pass through it. Okay, and the respiratory membrane doesn't allow the oxygen to quickly pass through it. Is it clear? So that's why small amount of pressure difference will move same amount of carbon dioxide, that 64 millimeter high pressure will allow the oxygen to move. So we say carbon dioxide, just write it down, is 20 times more soluble than oxygen. That's why even a small amount of pressure difference will move a lot of carbon dioxide through the membrane from one compartment to another. Okay. Factors influence the saturation. You know that hemoglobin carries oxygen, right? Hemoglobin carries oxygen, binds with oxygen, and that binding depends on few factors. How much saturation or binding will occur. Few factors can change the amount of saturation or binding. Just know that what are those factors? Pressure, oxygen or oxygen pressure, temperature, pH of blood, and pressure of carbon dioxide. First, pressure of oxygen. This is very simple. If oxygen presence is more, that means pressure of oxygen is more. Is it clear? Pressure of oxygen more means what? The presence of oxygen is more there, right? So that is very simple. If oxygen pressure is more, saturation will be more. Hemoglobin will bind with more oxygen. So that is simple. So pressure of oxygen more, that means more saturation. Now let's see carbon dioxide. If carbon dioxide pressure is more, then oxygen binding will be less, because carbon dioxide will also try to bind with hemoglobin, right? Because carbon dioxide pressure is high, so carbon dioxide will try to bind with hemoglobin more. So in that case, oxygen saturation will be less. So saturation. Okay, is it clear? So more oxygen, more binding, saturation. More carbon dioxide, less oxygen binding, we are talking about saturation of oxygen. Increased temperature. If body temperature increases, the saturation will be less. Okay. So, in cold, if the room is cold, you are, resting in a cold room, the binding of oxygen and hemoglobin will be better, okay, than in hot place. Okay, here you see the curve. This is called oxyhemoglobin saturation curve. That curve, normal body temperature is 38 degrees Celsius. So you see the first block, see the first picture, normal body temperature 38, and that's how the curve looks like. Now, if the curve shifts to the right, down to the right side, that means binding is less. If the curve shifts to the left, that means binding is more. Is it clear? If the curve shifts to the right, binding is what? Less. So now you see, if the body temperature moves to 43 degrees Celsius, the binding is less or saturation decreases. If the body temperature goes down, the saturation will be more. So outside of the body, you can do that experiment and see how much oxygen is getting attached to the hemoglobin. We can do all these experiments in the lab. And you can reduce the temperature and see. In low temperature, saturation of oxygen is more. That means more oxygen binds with hemoglobin. pH is another factor. If the pH goes down, you see the second picture, if the pH goes down, that means the saturation will be saturation will be less. So pH, increased pH means alkaline. Yes, so saturation will be more. If it is acidic, decreased pH, means acidic, right? Low pH is acidic. In that case, saturation will be less. So increased pH, that means less acidic, will increase the saturation. So here only carbon dioxide, increased carbon dioxide decreases saturation. Okay, increase oxygen, this one also, these two decreases saturation. Increase carbon dioxide, increase temperature, and these two increase saturation. Okay. So just mark this. I can show you why the increased pH, increased saturation, decreased pH decreases saturation. You see here, if carbon dioxide increases, just for you to know, probably I will ask you in the exam, if carbon dioxide increases, what happens? This is very important. You will see this later. Carbon dioxide reacts with the water and produces hydrogen ion and bicarbonate. This is the reaction. Okay, and that means what? More carbon dioxide in the body produces more hydrogen ion, and you already know from NP1, more hydrogen ion means acidic. If the hydrogen ion concentration increases, right, it becomes acidic. That means what? It is pH. Low pH means acidic. So now you see, these two are connected. If in your body carbon dioxide increases, more hydrogen ion will be produced. That means pH will go down. That will decrease saturation, because pH increases saturation, decreases saturation. So those two are connected. If carbon dioxide increases, pH goes down in the body. that decreases the saturation too. Okay. So those, just remember, those are the 4 factors that changes the binding of oxygen with hemoglobin. Okay. So let's stop here today.